Greetings. My name is Christine Mai. I'm a pediatric anesthesiologist at Massachusetts General Hospital. In this video, you will hear an inspirational story about dedication and determination in the formation of the first pediatric critical care medicine unit in North America by Dr. John J. Downs. Dr. Downs is a professor in anesthesiology, critical care medicine, and pediatrics at the University of Pennsylvania School of Medicine. He was the former chair of anesthesiology and critical care medicine at the Children's Hospital of Philadelphia from 1972 to 1996. He currently is a senior physician in the Division of Critical Care Medicine, as well as the medical director for the Pennsylvania Ventilator Assisted Children's Home Program. In this video, you will hear his stories of dedication and determination in the building of the cornerstones of pediatric critical care medicine as we know it today.
The concept of pediatric critical care medicine has evolved over the past 50 to 60 years as an outgrowth of adult critical care and neonatal critical care. I was privileged to join the staff of the Children's Hospital of Philadelphia in 1963 at a time when Leonard Bachman was chairman of the anesthesia department and C. Everett Koop was the chairman of the surgical department. Both of these individuals were very receptive to the concept that critically ill infants and children needed specialized care and that care should be delivered in a specialized unit. There were a number of problems, however, that prevented the immediate implementation of these two major concepts. The first was there were no trained pediatric intensivists, and secondly, there was no feasible area in our small old hospital that would readily be available to become a pediatric intensive care unit. I had the privilege and the support of the National Institutes of Health to undertake research in the causes and the treatment of acute respiratory failure in both infants and children beyond the neonatal age, as well as in premature newborn infants. And we did have a neonatal intensive care unit based at the Pennsylvania Hospital, which was the primary neonatal unit of the University of Penn healthcare system. I was able to work under a fine neonatologist, one of the pioneers in the field, Thomas Boggs, and he taught me a great deal about the care of the newborn infant, particularly the premature newborn. We did undertake mechanical ventilation for the neonates with respiratory distress syndrome who developed acute respiratory failure, and I learned a great deal from that experience and was able to subsequently translate that to the care of older infants and children. In late 1966, a surgeon, Dr. Harry Bishop, who was president of the medical staff, came up with a logistical plan that would enable us to cohort children with respiratory failure or other life-threatening conditions into an area adjacent to the operating rooms. And through the movement of several units and relocation of those units within the hospital, we were able to obtain a 6-bed pediatric intensive care space adjacent to the operating rooms and the recovery room. And it was this space in which we established the first pediatric intensive care unit, to our knowledge, in North America, which had a full-time staff, had a full-time blood gas laboratory, full-time nursing and medical staff. We opened that unit in January of 1967. I was the medical director. We had a fellow, Theodore Stryker, and we had pediatric residents rotating through, and we had a full-time nursing staff who proved to be excellent. And this staff were nurses who had taken care of post-operative cardiac patients who had worked in the neonatal intensive care unit and who had worked in the recovery room. We were able to also take care of post-operative cardiac patients who became younger and younger in age. Our cardiac surgeon, Dr. John Woldhausen, was a great supporter of the concept of pediatric critical care, and our head of ear, nose, and throat, Dr. Sylvan Stuhl, helped us in many ways with airway problems and with the care and subsequent decannulation of children with tracheostomies. This unit served as a prototype for the development of other units in North America. We had been preceded by units in Europe, the first being in Gothenburg, Sweden, another one in Stockholm, and another one in Paris, which I happened to visit in 1964, founded by two former neonatologists, Jolie and Humer and Huot, and the unit at the Great Ormond Street, a respiratory care unit, headed up by Ian Aberdeen, a surgeon, and David Hatch, an anesthesiologist. With the experience of those individuals and my own experience in neonatal intensive care, I was able to establish a curriculum and a series of protocols that helped us care for children with various life-threatening conditions, particularly respiratory failure. The unit served as the prototype for our new hospital, which opened in June of 1974 and is still the main hospital of our children's hospital system. In that building, we opened a 20-bed pediatric ICU with a separate 6 beds for isolation. That unit, I thought, would see us through to the end of the century, but as luck would have it, within a year we had to open up expansion space to add 10 more beds, primarily because of the development of children requiring long-term mechanical ventilation. Subsequent to that, we had to develop a home care program, which is really shifting intensive care out of the hospital and into the home, and in 1979 established a formal ventilator-assisted children's home program in order to take care of the children who could not be liberated from mechanical ventilation, but who were sufficiently stable to go home, be cared for by their parents and nursing assistants.